listening to the ASN Kidney News Podcast. Rahim MD Fasan and Naeem Rahim MD are brothers who are nephrologists in southern Idaho. They are also recent recipients of the Ellis Island Medal of Honor, recognized for their work in the area of rural healthcare. In this episode, ASN Counselor Ronald Falk MD Fasan speaks with the Rahim Brothers about their work.
Hello, this is Ron Falk for the American Society of Nephrology, and today our guests are the Rahim Brothers from southeast Idaho, and we're here to talk with them about a number of subjects. But first of all, welcome to you both.
Thank you.
Thank you, Ron. Good to be here.
First of all, paint us a picture of where you practice. Tell us what southeast Idaho looks like and your practice there.
I'll go for it, Ron. So I'll tell you, I'm sitting in my office looking out the window of beautiful mountains surrounding me, capped with snow, and nice lush greenery around it. So it's really nice and sunny and beautiful, so it's great to look outside my window right now.
I would just say Rahim is probably sitting in my office. That's why he's got such a good view. It's a gorgeous country. It's a place where you can ski in the morning and golf later in the day. You've got the best trout fishing in the world. And if you choose to do any of those things, this is heaven.
How did you wind up in Idaho?
Rahim got out of the practice first, and he went to Florida to join the practice. And luckily, he chose to be the year that he got like 3 hurricanes land on the city that he was living in. So when he sent me an invitation to join him in his practice there, I said, no, thank you. And I looked around and I tried to convince Rahim that we need to start our own practice. And we looked around the whole of country, and in the end we decided on Idaho because it was the least served, the most appropriate for the kind of things Rahim and I wanted to do. And,
so let's talk about that for a minute, because both of you have been commended for your work in preventative care in an area which has limited access to physicians. So tell us what kind of preventative care and how you deal with a limited access issue.
Ron, just a part of the previous question also, we decided to move out here because we were truly looking for a change in personal and professional lifestyles. Personally, it's been very gratifying, and so as professionally. We were looking for underserved areas. This was truly underserved. When we started our practice, the first thing we realized truly was we need to invest into technology, and that's kind of what we did starting from 2005. But we also realized that we have to truly invest in educating our patients, our communities, our physicians, our peers and colleagues. So that's kind of what our take was from the very start.
And if you realize, Ron, these are the communities that haven't had nephrologists around for a long time. I used to jokingly say, you have more nephrologists in Valhalla, New York, where we trained in New York Medical College, than you have in the whole state of Idaho. There are like 7 or 8 nephrologists, and 2 of them are related. And it really was a pivotal point for us when we came here and we recognized that these people were doing the best job they could, given the circumstances, for a pretty large population without a nephrologist. And education became the priority number 1 for the physicians and the staff in the community.
Rahim, do you want to add to that?
This was really like a sponge, so we didn't really have to go to too far extremes to educate our people. Very simple things. Just giving you an example, in 2005 when we started, a common consult for physicians or nephrologists for us is, okay, we'll call the nephrologist when the patient needs dialysis. Or nephrologist is basically a physician. The common scenario was who will be called at the time the dialysis is needed. So changing the simple perception that we're not truly dialysis doctors, our primary job is to prevent dialysis and take care of problems earlier on, has been phenomenal. So starting with a very simple change of thought process, and I'm talking not only patients but also physicians at large, because they didn't have access to nephrology that available readily, and they did the best they can and seek help towards the very end.
How do you deal with people, however, who really are in critical condition, the acute kidney injury cases? Do they all come to a central place, or are you on the road a lot?
For the last 6 years, we had a need to grow. So we started, just to give you the scenario, we started from southeastern Idaho. For the first town where we landed was Pocatello. Then there was another town about 30 miles north of us, Blackfoot, and then another 25, 30 miles north, which is Idaho Falls. So we've kind of established 3 practice regions where patients have access to care over maybe 45, 50 miles radius. We travel between them. Patients can now access those areas, but mind you, I mean, our catchment area right now is close to 200,000 patients, so patients still sometimes have to drive 3 hours to reach Idaho Falls office, but the communities that are living around us used to drive 3-4 hours to go down to Salt Lake or Boise before that to seek help for clinical nephrology. So we have access points available now where we see patients, and on a daily basis, patients thank us because now they live 3 miles away, and previously they had to drive 3-4 hours to get care for their chronic nephritis that they're being treated for, or plenty of transplant patients. I mean, huge population of transplant patients that we were surprisingly tapped over the last 6 years, and then streamlined their care.
And coming to your acute kidney injury point, there are very good hospitals in the area that have been providing very good service over the years. Pocatello has a hospital called Fort Neff Medical Center that just spent $300 million to create a brand new hospital from an older hospital, and that is providing excellent care in all fields and specialties. And similarly, Idaho Falls is a hospital called Eastern Idaho Regional Medical Center, which is a level 2 trauma center. These hospitals have been there, but interestingly, did not have nephrologists. People were doing their best to treat acute kidney injury, but again, even now the fact that patients know that there's an Idaho Kidney Institute. Physicians,
right. I mean, Fort Neff Hospital,
surrounding areas know all this as well, and they refer their patients to us, and hence the acute kidney injury time lag has shortened because of our presence.
Our listeners should know that in 2007, both of you were recognized on the floor of the U.S. Senate, noted your work that has helped close the gap in healthcare for lots of people in Idaho. So whatever you have organized there really has already achieved national attention. What recommendations would you give to somebody just starting out who wants to improve the care of patients with kidney disease in relatively rural areas?
These are the benefits of being in a smaller community. I don't want to belittle anybody by saying that whatever I did or Rahim did was above and beyond what nephrologists are doing every single day in this country or other physicians. The only difference is we're not part of the rut anymore. What we do shows up. The benefit is the good that you do shows up. And, of course, on the other hand, if one does bad, that shows up fairly quickly, too, like a jungle fire. These are small communities of 250,000 people all scattered around the place. What my recommendation for newer physicians is always that this negative connotation that is associated with the word rural medicine needs to be removed. I think this is something that needs to be, in present day and age, we are not actually rural anywhere in the United States. And Rahim and I have done our best to create these kind of and help new physicians over the years with our practices. We have an entity called Nephro Consultants. Rahim can talk about that, helps newer physicians get into places and establish their practices based on the idea that we did. I'd like for him to talk a little bit more about it, but that's where we start them.
Truly, just like what Naeem said, when we combine two words, rural and medicine or rural and healthcare, it does have a little bit of a negative connotation. And truly, in today's age of technology and availability, and if we truly use education and technology together, I think we can really cross plenty of barriers. And that has been the pivotal reason why we've been able to do what we've done. And so the first suggestion will be to truly be open for ideas. We were fellows at one point, and when we were about to graduate, all we were looking for, the recruiters calling us in all kinds of areas, and anytime we will see a name we would not recognize, state-wise, location-wise, it would just, tame us down. So I think we should be open for it. Ideas also need to come from fellowship programs. I personally believe, and I think that's can be where ASN can also help in this regard, is that the program directors need to put in a volunteer program where a fellow in their first year fellowship can go and spend on volunteer basis 2 weeks or 3 weeks or whatever choosing is, and come and spend some time with physicians like Naeem and I and see truly what can be done. And I think that would be a great startup point for the future.
Let me push on this technology question for a minute. There have been a number of attempts by state and federal commissions and government to push technology as a way of helping physicians and patients in rural environments. When you say that nobody's really rural in America, to a certain extent that's true, just as long as they have access to the internet. How have you practically used technology to bridge those distance gaps?
One of the things we do is, like I said, our practices are scattered over 45, 50 miles, but our catchment area is as far away as 250,000 people, 3-4 hours long drive. We, on regular basis, will communicate with our physicians. Sometimes they cannot send a patient down to us, so, it's not truly telemedicine, but, we've done Skypes with them. We've done online communications with them, a lot of email interaction, exchange of information through web. We've created 2 good websites which we try to update as much as possible with education material. We are always directing on every interaction with the patient to go to our website and get more information, encouraging them or their family members. There always is a family member. But truly, access to internet is the key. That's where it needs to start from. But which is definitely a lot better now than it was in 2005 than we were started off with.
And another thing that we are trying to delve more into and get ourselves more involved with is the social media aspect of things. Doctors, especially nephrologists, are not into the social media for their practice as much as we would like them to be. And Fahim and I, our next campaign is to get ourselves YouTube channels and Twitter accounts that tend to stay in touch with our patients in regards to the educational aspects, so they have a constant stream of information going both ways. That is our next big thing on our agenda on our table, and we've been working very hard to have that materialize in the near future.
You two could form the nephrology equivalent to Car Talk with 2 brothers. But you'd have to change. You'd have to come up with some jokes and things like that, and have call-in. It could be just fantastic. It picked up by NPR. I can see it now.
You'll be amazed at the amount of bickering that happens between us directly and indirectly. Let me give you an example. Every time he's rounding, if he's a week before me and doing the hospital rounds, and if the patient has never seen me, he will leave the patient with this statement at the end saying, by the way, please don't laugh at my brother when he shows up tomorrow. He's 4 feet 5, and he's missing a couple of teeth, but he's a good doctor. Every time I enter that room, patients start laughing on my face, and I don't know what to do with it. My statement for Fahim is usually that I'm the better-looking Rahim, and that's the most famous catchment. I say I'm the better-looking but less intelligent, because you can always get brains, you can never get looks. So that tends to work very well.
Let me move us to another subject, and you both deserve tremendous congratulations on being named the Ellis Island Medal of Honor recipient. So this is an honor from the National Ethnic Coalition of Organizations, and they sponsor the Ellis Island Medal of Honor Awards each and every year. And for our listeners, this award recognizes individuals who have dedicated themselves to community service, who typically have honored their own histories and traditions of a specific ancestry group, and who have tried to bridge the bridges between the ethnic and racial and religious groups in the United States. So a couple of questions. The first of which is, how did you get this award? How did they find you, do you think? And what does it mean to have received this prestigious award?
I guess I'll go for it. So, Ron, truly, you're right. I mean, this is truly a prestigious award, and just a background on this. I mean, every year they get about 8,000 or 9,000 nominations of people who are truly out in the fields and trying to make a difference on a day-to-day basis. So they're always looking for people who are doing this. Out of the 8,000 or 10,000 nominations they get, they select 85 to 100 medalists. I guess people back in the East, when we left, have been watching our careers, and, when we were leaving, people were curious why we were moving to Idaho, and we said, we want to make a difference. We don't know what we're going to do, but we truly want to do something. So truly, it's a great honor. I mean, once again, to be counted among names like Joe DiMaggio, Colin Powell, 6 U.S. presidents have received it, as you must have read, and including multiple Nobel laureates and Muhammad Ali. So we're truly honored to be part of the same ranks, at least counted among. So, but the reason is. What this celebrates is the great American, cultural mosaic where people from different cultures can come from different walks of life, stand together, and truly can make a difference. So it's an honor to be part of this, and I guess, what we decided we wanted to do 6 years ago has truly, showing some difference.
Now that you've achieved this milestone, and it's a major milestone, where are you headed next? What's your next?
Well, I plan on retiring, so.
No, I truly, I'll say a couple of quick words to name, and then you can chime in. I think truly it's an opportunity, like any other opportunity, to do more. I think my next step for me will be to take it to the next level and inspire more people and to create more hope and build more bridges among not only cultures and religious barriers, but also, keep doing what I do best, which is among healthcare. I think there are plenty of bridges that we need to build among our referral bases and our patients, and truly inspire the next generation of fellows. I mean, there are hundreds of fellows who are going through training programs and going back to them and communicating with them that, even in today's day and age, you could be like someone who can make a difference, and don't hesitate in trying new ideas and new experiments and doing something that somebody would think that you're totally crazy to try to attempt.
In that regard, if you want to influence trainees, Idaho doesn't have its own medical school, so it's part of the WWAMI program. Washington, Alaska, Montana, Idaho. Have you folks interacted with WWAMI?
Yeah, WWAMI is a great program. It's been there for years and years. 20 of our residents, local people, go to the WWAMI program every year.
Family medicine.
Deep down, I'm a little surprised that we don't have a medical school. Coming from a country like Pakistan originally, one of our greatest exports is physicians. And for some reason, I can never understand why we don't have a distributive type of a program that will provide medical education for the state of Idaho, by the state of Idaho. But the WWAMI has done a good job training a lot of our students. The problem with the WWAMI that I've felt over the years is probably not a lot of those students end up being in rural Idaho. A lot of them go to Boise, a lot of them go to specialties in the future, which is fine. There are good residency programs. There are WWAMI residency programs that we interact with. There's one in Boise that we don't have much interaction with, but there's a great program in Idaho State University, family medicine residency program, which trains physicians every year in family medicine. And we are the affiliate faculty with Idaho State University, and the training of those physicians, a lot of those have stayed back into many rural communities around us. And these physicians have turned out to be great referral sources, as well as great physicians from a nephrology point of view, because they have been trained well enough that they pick up chronic kidney disease much earlier, the signs and symptoms of acute kidney injury, the prevention aspect of it that we have gone over the years of their training. And they are great physicians out there who are providing us with patients who are coming in much earlier because of that. So in many ways, that has come out to be really good for us.
Right. I mean, I'll just say a couple of lines on that. So we have been involved in their education with the family medicine residency program, and we've truly seen a difference once these graduates have decided to stay in the community. So just giving the example what I said earlier, previously, somebody would call you, okay, this patient needs dialysis, and now the same, family medicine residents who are now practicing will call you, and we are honored to say that, Dr. Rahim, I have a patient with stage 3/4 kidney disease, and I've done the metabolic bone disease profile, and the ultrasound has been ordered, and I'll let you follow up on this. And so things we've seen truly a difference in the thought process by just interacting face to face and educating and doing grand rounds with them and having them come and rotate with us in the clinic for a couple of weeks, during their 30 years and things like that.
thank you, both of you, for spending time with us on this ASN podcast. It's really a pleasure to talk with you. And again, congratulations on your awards. This has been Ron Falk for the American Society of Nephrology, saying goodbye.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. The information in this podcast should not be used during a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.